Good morning. Can you hear me with this mic okay? Okay. I'm a gastroenterologist, so I won't be talking about MS. I'm talking about Crohn's disease or inflammatory bowel disease. And first I'm going to give a little bit of background, try to simplify this very, very complex condition and opioids and understand a little bit about their receptors for any of the non-scientific people in the audience. It's even complicated for us scientists. So talk a little bit about the role of the opioid system in inflammation and what we know about it from our studies in cancer. Talk about the hypotheses that are with the mechanism of action, and then the clinical trials that I've done in inflammatory bowel disease. So endogenous opioid peptides play a role in neurotransmission. They serve as potent regulators of growth. They influence cells undergoing cellular repair. They augment the immune system, and they induce this feeling of overall well-being. And there's 4 things that you should be aware of that can increase your endogenous endorphins and enkephalins. The first is eating chocolate. Yes. I love chocolate. The second is exercise. You've heard about the runner's high, and that's because when you exercise rigorously, it increases your endorphins and enkephalins. The other is having a deep spiritual, religious experience. And the last one is sexual activity. So we'll skip that one. But those are the 4 things that can raise your endogenous opioids. So what are opioid peptides? We talk about opioids, and these are opioids, these are proteins that are made within our body. Endorphins and enkephalins are the main ones we'll be talking about today. And like I said, they can cause euphoria, runner's high, help with healing in the immune system. Now there are synthetic opiates, which are shown over here, and we're all familiar with these narcotics because they're mostly used for analgesia or pain control, but they're also used for sedation and diarrhea. So just a little bit about, hope I didn't miss it, opioid receptors and what we know about them. There's 4 main types of opioid receptors. It's the mu, delta, kappa, and what we call the OGF, or opioid growth factor receptor. And the mu, delta, and kappa receptors are what we call the classic opioid receptors, and that they're located on the outer plasma membrane of all sorts of cells. And these are the different proteins that bind to these receptors. Now, we're mostly familiar with the mu receptor because it's involved with pain control, and that's where morphine works primarily on that receptor. But there are other receptors that are involved with inflammation, like the delta receptor. Now, the OGF receptor, and it's called the opioid growth factor receptor because it happens to be the only receptor that's a little bit different. And it's located not on the outer part of the cell, but it's located on the nucleus, on the nuclear membrane. And it's the only one that's involved in growth and healing. So what is naltrexone? Well, naltrexone's a drug. It's a synthetic drug, and it's very small in size. Here's its chemical structure for any of the chemists in the room. And it's a non-specific, long-acting opioid receptor antagonist. That means it binds to all 4 of those receptors, and it blocks the effect of the proteins that normally bind to them. It decreases TNF-alpha and other inflammatory cytokines that you heard about from inflammatory cells. And it is approved by the FDA at a 50 milligram dose for alcohol withdrawal syndromes. It's generic, and it's inexpensive. There are a whole bunch of other synthetic antagonists and agonists that are out there that you may read about in papers, and I'm not going to go into these in details, but just to mention that the non-selective ones are the naltrexone and the naloxone, which is much shorter acting. And I also just want to mention a little bit about the mu receptor because The mu receptor we hear the most about, and it's the most that's out there in the literature, but it has a very low affinity or a low attraction for enkephalin and for naltrexone. And it has the opposite effects of the other delta and the kappa receptors when it comes to inflammation. And so if you actually block the mu receptor, it increases inflammation. Whereas if you block the delta receptor, it decreases it. And if the mu receptor is stimulated, inflammation decreases. So, for example, if you have down here enkephalin or naltrexone, I hope you can see that at the bottom, most of the circulating enkephalin and naltrexone will have an affinity to bind to either the OGF receptor or the delta receptor over the mu receptor. But if you add too much naltrexone, then it will have a tendency to go to the mu receptor and have opposite effects. So a little bit that we understand, and a lot of this comes from my partner Dr. Zagon's work on homeostasis regarding cell growth and the opioid growth factor receptor. We know that the normal cell has opioid receptors on the outer plasma membrane. It also has the OGF receptor on the membrane of the nucleus. And all of our cells in our body make, and most of them make enkephalins and endorphins, and they secrete them out into the circulation. Now, under normal conditions, when enkephalin is present in the circulation, it helps to maintain normal growth of cells so that your cells don't grow out of control. But for some reason, if the amount of enkephalins or endorphins are not present to the extent that they should be, it may end up to cause abnormal growth or cancer growth. So the cells grow out of control. And this is from a paper that Dr. Zagon published, trying to understand a little bit about the growth effects of OGF, which is the same thing as metenkephalin. Because the OGF receptor binds metenkephalin, we just refer to metenkephalin. If you hear them, they mean the same thing. So OGF, or metenkephalin, is also small. It's only 5 amino acids. And it can go right through the plasma membrane, and it binds to the OGF receptor, which is in the nucleus. Now, through work that Dr. Zagon and McLaughlin have done, they found that after it does this, it actually increases some of these, they're called inhibitory kinases, P16 and P21. Not important for this discussion, but when those go up, it actually down-regulates cell growth. So it shuts down cell division. So that's part of the mechanism, how it helps regulate the cell growth and keep cells under normal controlled growth. And it's really important that we understand why use low-dose naltrexone instead of high-dose naltrexone. And I just showed this slide, and this is using ovarian cancer cells. And what Dr. Zagon's group has shown is that if this is a control that has no naltrexone given, if you give a short dose or low dose naltrexone, you can inhibit the growth. But if you give too much, you can actually stimulate the growth of these ovarian cancer cells. So why is that? And he also showed under the same conditions that the only receptor that actually is involved with growth is the nuclear OGF receptor. And if you add the low-dose naltrexone, you can mimic the effects of OGF or enkephalin. But it does not act on any of the other receptors at that. So the only receptor involved in regulating growth in the cancer is the OGF receptor. So why do we take just a low dose? Well, this is one of the hypotheses that you've heard about, and that if you take a small amount of naltrexone, shown here with an N, it's thought to last in the system about maybe 4 to 6 hours, and it blocks these receptors from working. When they're blocked, the cell says, oh, I need to make more enkephalin, so it makes more of the enkephalin. And then after the naltrexone wears off and it goes away after the 4 to 6 hours, the enkephalin or OGF that's circulating in the blood then can bind to these receptors, and that causes decreased cancer growth. But if for some reason too much naltrexone is given, and after the 4 to 6 hour period it's still hanging around and it's still blocking the receptors, the cells are making more enkephalin, but the enkephalin cannot interact with the receptor to have its effect. So that's one of the hypotheses on why we use a low dose of naltrexone, and actually that the low dose is mimicking us giving enkephalin or the metenkephalin. So just as a little bit of wine might be good for you, a little bit of naltrexone might be good for you too. It can help restore the immune system, regulate growth, but too much of a good thing can be harmful. So some of my patients who say, just only 1 glass of wine, right? Okay. So as far as the mechanism of action, one of the proposed mechanism of action is that the low-dose naltrexone, and it's been only evaluated in cancer cells. So I want you to understand that all these growth effects and the short-term effects have all been evaluated in cancer cells. And it's possible that cancer cells may not respond to the low-dose naltrexone the same way that other cells do. So it might be different. And maybe in different conditions in autoimmune diseases and Crohn's disease, it might be a different mechanism. So the mechanism that the LDN works in the normal cells and the immune cells, like I said, could be different. And we all talk about how when you block the receptor enkephalin levels go up, and I'll show you later that we never found that to be the case. It may be because we didn't measure it at the right time. But even the paper that's quoted on that, which is from one of Dr. Zagon's paper, it was done in neuroblastoma tumors in mice, and the only place where the endorphins went up was in the tumor tissue itself, not in the blood of the animals. So, anyways, I'm a gastroenterologist, and I've been involved with Crohn's research for many years. And with my research, I was working as a principal investigator doing clinical studies for industry, and I was involved with treating patients with biologics. And I won't mention the company or the drug, but we were going into the 3rd phase of one of these biologics, and the IRB, which is our research committee, asked me, are the benefits of this drug better than the risks? And I looked up in my office, and there was an entire bookshelf filled of notebook upon notebook of all the side effects that had been reported to the FDA and around the world for people taking these biologics. And ethically, I couldn't justify that the benefits were better than the risks. So it was at that point I got an idea. So I just said, we need safer drugs. There's a problem with using all of these drugs in our patients. So what is the role of opioids in inflammation? And we heard a little bit about that from Dr. Chopra. We do know that the chronic use of narcotics reduces immune cell function. And in our Crohn's patients in particular, it's known that people who take chronic narcotics have more complications, have more infections, and have shorter survival. So the narcotics are contraindicated, really, in these people. Opioids are known to inhibit these different inflammatory chemokine reactions. And we do know that the immune cells express the opioid receptors, the mu, the kappa, and the delta receptors. And that the immune cells also secrete opioid peptides, such as the enkephalins and the endorphins. And they've also been shown to induce the release of different inflammatory cytokines, which we'll show a little bit in our mouse model. So what is Crohn's disease? Well, inflammatory bowel disease is a condition that causes inflammation of the intestine, and the 2 main ones are Crohn's and ulcerative colitis. Crohn's disease, which actually we now also know that people who have a mutation, thank you, Dr. Chopra, in a Toll-9 receptor have an increased incidence of Crohn's disease. And in Crohn's disease, the Toll receptor is in the intestine, and it helps recognize which bacteria are friendly bacteria and which ones are bad bacteria. And if they have a mutation in this receptor, they can't recognize it, so they set off an inflammation. So that's what the toll receptors do in Crohn's disease. But Crohn's disease can involve inflammation from anywhere from the mouth all the way down to the anus. And ulcerative colitis only involves the colon. And the way we approach these diseases is a little bit different in that today, Crohn's disease, they do what we call a top-down approach. Most of the gastroenterologists go for the big guns first. They go with the biologics first because using some of the other drugs, even though prednisone works, they take longer and they are not quite as effective. And so they recommend starting up here with these anti-TNF monoclonal antibodies and working down. Whereas with ulcerative colitis, because surgery can be curative, we tend to start with the less toxic drugs and move up. And also in ulcerative colitis, the biologics don't work as well. The biologics, even though they're the first-line treatment today, only work in anywhere from 30 to 45% of the patients with Crohn's disease. But there are some risks with taking the biologics, and these risks, if you want to swim with the sharks, include infections, reactivation of tuberculosis, chronic Clostridium difficile colitis, reactivation of hepatitis B, and lymphoma. And the risks, even though they're not real common, they do occur. So wouldn't you rather swim with the dolphins than with the sharks? I would. So one of the models that we have for understanding inflammation in the opioids and inflammatory bowel disease, the Th1 is thought to be the inflammation involved in Crohn's disease. And these inflammatory cells release interferon gamma and TNF alpha, and they stimulate macrophages, which is another inflammatory cell, and then that releases inflammatory cytokines. Well, these cells have opioid receptors on them. And the opioid receptors, certainly then they release opioids and they respond to opioids. And then if you add naltrexone, you can block the effect of the opioid receptors on these inflammatory cells. So this is Crohn's disease. It's thought that there's a different type of inflammatory system involving IL-13 for ulcerative colitis, but they all involve inflammatory cells, and there are opioid receptors on the inflammatory cells. So in inflammatory bowel disease, as far as the mechanism of action, one possibility is that we block these inflammatory cytokines when we use naltrexone, and that causes the lining of the bowel to heal. Another possible mechanism is that by using a low-dose naltrexone, it might act on the OGF receptor to cause some healing and growth of the ulcers that these people have in their intestine. So several years ago, we thought I'd test this in an animal model, and there's a number of animal models to study inflammatory bowel disease, and I actually used the DSS model. It's a chemical you put in their drinking water, and all the animals get colitis. And what we found was that the animals, these were the untreated animals who got the chemical, but when we added the naltrexone to their treatment, we had significant improvement in their activity score, and we had improvement in the histology. These black boxes just show that naltrexone by itself doesn't have any deleterious effects on the bowel. And what we did see when we looked at their intestine under the microscope is that this is a normal intestine in a mouse, in case you're interested. Humans look very similar. But this one is very inflamed, and all these black dots are inflammatory cells. And then after the naltrexone, you can see that we start getting the bowel restored back to normal. The other thing that we found in the animal study was that the naltrexone actually did reduce these inflammatory cytokines. So these are known inflammatory cytokines that are elevated in Crohn's disease, and these are the animals that had the chemical. It went up in them, and we were able to completely reduce that, or significantly reduce it with the naltrexone. So then, based upon the mouse studies, we moved on and thought we would try a pilot trial in humans, and this paper is published in the American Journal of Gastroenterology. And this was really just to test the safety and toxicity of giving naltrexone to patients who had Crohn's disease. And we used a couple of indicators. The Crohn's Disease Activity Index is a standard scoring system that we use to see if people respond to medications. And in order to get into our study, people had to have active disease. And based upon this scoring system, if they had a score of 220 or greater, that meant that they had active disease. And we had some exclusion criteria also. And what we found in these subjects in our pilot trial is that compared to baseline, and you can see these were people who were already still taking medications and their disease was not well controlled, that we had significant drop in their scores after the 12 weeks of the naltrexone, and even 4 weeks after stopping the naltrexone, they were still doing pretty well. So we were pleased with this, but it also improved their quality of life. And in this study, we did see that some blood tests, you may be familiar with a SED rate and a C-reactive protein, those went down, indicating that there was less inflammation. Because naltrexone is known to be a possible hepatotoxin to the liver, we followed liver enzymes and they were normal. And the chemistries were all normal. It didn't reduce the immune system. We did measure enkephalins in the blood, and we didn't see any change in the enkephalins. So just to summarize, in this pilot trial, we did see improvement and decreased inflammation. But one of the problems with doing an open-labeled study is that, everybody knows they're getting the drug and they think they're going to get better. So it had small numbers. And now the strategy for treating people with inflammatory bowel disease is to look inside the intestine and make sure that your treatment is really healing the lining of the bowel, not just that they're feeling better. So then I did a phase 2 placebo-controlled double-blind study. And in this study, we screened patients based upon they had to have active disease, and then they were randomized into naltrexone or placebo based upon how active their disease was and where it was located. And then for the first 3 months, it was blinded, and people either got naltrexone at 4.5 milligrams or a placebo. And then at the end of the 3 months, they underwent a second colonoscopy. So they had a colonoscopy up here and a colonoscopy down here. And then we still didn't unblind it. We didn't know who was taking what. But then we went into an open-labeled part where we treated everybody then with naltrexone. And that actually helps to recruit patients into a study if they know eventually they're going to get the treatment. So they were willing to take a placebo if they knew they were going to get the drug eventually. So then they had a third colonoscopy. So 3 colonoscopies in 6 months. They didn't have to pay for it. So what we measured in this study, our primary outcome was to see that there was a decrease in the Crohn's Activity Index. But our secondary outcome was really to look at the endoscopy by the colonoscopies and see if we had healing. Did it really make a difference? And one of the things that really I just want to point out to you, comparing our placebo to our naltrexone patients, at the beginning, we didn't randomize according to their activity index score, and it turns out that the people who got the randomized to naltrexone actually were sicker. Their Crohn's activity index score was 365 compared to those who got the placebo. It wasn't significant, but they were basically a little bit sicker. So we had to have a greater improvement in them to be significant. But we did meet the primary outcome, and there was significant improvement in the people who got the naltrexone in the first 12 weeks of the study compared to the placebo. And we also looked at the endoscopic score after the 12 weeks, and what we found was that with the naltrexone, there was significant improvement, and this is just somebody looking at the colonoscopy, taking pictures and scoring it, and showing that it was better. And what we saw was that with endoscopic remission, that no one went into remission who was on placebo, but 44% went into remission in 12 weeks on naltrexone. Now, what we did in our study that other studies have not done is we also did biopsies. And even though patients may tell you they're feeling better, and maybe somebody looking in the colonoscope may say, well, this might look a little better, but biopsies don't lie. And what we saw is that, you know, people who were on placebo for 12 weeks, there was absolutely no improvement. They still had inflammation, whereas those who got naltrexone had significant improvement. And this is just a picture that's from our manuscript showing somebody who was on naltrexone and the corresponding biopsy from the same site showing that after 12 weeks they had healing of the lining, whereas somebody on placebo had no improvement. I just want to mention we did look at side effects in this study, and a lot of people say that the low-dose naltrexone causes insomnia. I'm not going to say that it doesn't, but in our study, the same number of people who were on placebo as were on naltrexone complained of insomnia. So insomnia is a common side effect whether you take low-dose naltrexone or not. And fatigue was the only side effect that was significant, and that people who were on placebo complained of fatigue. So we did have two subjects in our study that flared up. One was on naltrexone and one was on placebo, and the one who was on the placebo got randomized then onto naltrexone, and he responded. I did have one patient who had this reflex sympathetic dystrophy, and her neurogenic pain got worse on the low-dose naltrexone. But her Crohn's got better. We did have two subjects whose liver enzymes went up transiently. We never stopped the naltrexone, and they went back down. But we do, and the FDA, if this gets approved, will probably recommend that people who take the drug get periodic liver enzymes checked. So, and then we went on after the 12 weeks, and we looked what happens if can we rescue these people who were on placebo. So this is an open-labeled part of the study. And just a couple of points to make from this part is that those who were on placebo did get better. The people who we continued on the naltrexone also continued to have some improvement if you go beyond the 12 weeks by their Crohn's disease activity index score. And the number of people going into remission was actually 50%, which is better than some of the biologics that are out there. But another point that I want to make is by the endoscopy, people say, how long do I have to take this till I know it's actually working? By our endoscopy, if it's going to work, we saw improvement at 12 weeks. Going beyond that, if you're not going to improve, it's probably not going to get any better if you continue by the endoscopy. So this just shows that going from 12 weeks, it was a little bit better, but it wasn't statistically significant. We also saw a reduction in the cytokines when we measured them by the blood. Again, we didn't see any change in the enkephalin levels. So just to summarize, that this study has also been published in Digestive Disease and Sciences, and a take-home message is that in order to get gastroenterologists or other medical doctors to prescribe this drug, it's important that we do good placebo-controlled trials, and we publish them in peer-reviewed medical journals so that the medical community accepts this work. Now, I want to move on to our last study in Crohn's disease in children. And first of all, I want to thank Mr. Bell, who's here in the audience, because this would not have been possible without him giving a donation for us to proceed with treating children. So thank you, and let's thank him here. You have no idea how many parents are grateful to what you've done. So, and this has been published also in the Journal of Clinical Gastroenterology. But children with Crohn's disease have a unique set of complications, such as if you use prednisone in children, they don't grow properly. Also, if children are having malabsorption and malnutrition because of their diarrhea or they're not eating with abdominal pain, they don't grow as well. Children also get depression. They cannot participate in sports. They cannot do sleepovers with their friends. So it really has a lot of different factors in children than it does in adults. And also taking medications when you start off with the disease when you're under 10 and taking it for a lifetime is something to consider. So the reason why that's important is that these medications that are being used for Crohn's disease also may have increased risks in children. And they cause infections, growth retardation, as I mentioned, but they also increase the risk of leukemias, and there's a specific type of cancer called hepatosplenic lymphoma that occurs in children, primarily young men, teenagers, who take biologics for inflammatory bowel disease or other conditions. And because of this, the FDA has issued a black box warning on the anti-TNF alpha biologic drugs in children. So we wanted to test the hypothesis of whether we could treat children with low-dose naltrexone and do it safely. And we actually did it, if people ask, in a liquid form that was banana flavored. And the placebo was also banana flavored. And we looked at, the children have a little bit different activity score that includes a diary for their symptoms, blood tests, and a physical exam. And they're in remission if their blood test is less than 10. They have moderate disease, or they have mild disease if they're between 11 and 29, moderate disease up to 45, and severe disease at 45. And a response to therapy is a decline by 10 points, and a flare is 12.5 points. And this just shows, in our study, we included only patients that had a score greater than 30. So everybody who came into our study were people who were not doing well on their standard treatment, or their parents just didn't want to give their child a biologic, and their child was not doing well. They had moderate to severe disease. And so we did a very similar study design as we did with the adults. However, the FDA would not allow me to put a child on a placebo for 12 weeks. They felt it wasn't ethical. So we tried 8 weeks instead, and the FDA approved that. And they were randomized to either get naltrexone or placebo for 8 weeks, and they came in for monthly visits. And and then these were the inclusion criteria. As I said, they were allowed to stay on their stable medications. We didn't stop any medicines for them to enroll in this study, but they couldn't change the dose that they were on. And our primary outcome was, again, looking at the Crohn's disease activity index score, but we looked at a lot of other factors in children, including the quality of life and their growth. And just to show you on the demographics here, these were the age of our children. Already, almost 20% of these kids had failed biologics, but the majority of them were taking other immune suppressive medications. And this was the clinical response in our study, and we did the analysis with what we call intent to treat. That means even if somebody flared up, like this person did, they were included in the analysis. So compared to the placebo, there was a significant reduction in the activity score in the children, and these are the individual scores. And you can see almost all of the children had a response to naltrexone. This child flared and didn't do well, and we rescued her with steroids. There's a child in here that had absolutely no response. But if I told you that low-dose naltrexone worked 100%, you would tell me I was crazy. So it doesn't work on everybody, but there's a large portion of children that responded to this treatment. And we did look at different markers, and we found none of these were significantly different because 8 weeks is a little bit too short a time. But the things that we looked at that have to do with nutrition were getting better. The markers that have to do with inflammation were going down, and the hemoglobin or blood count was getting better. We also looked at the side effects in our children, and again, sleep disturbances were the exact same whether they were on a placebo or whether they were on naltrexone. But there were none that were significant. And then in the quality of life, we had significant improvement in the quality of life of our children, and this is broken down into different scores. So their social quality of life improved, their systemic, their overall well-being improved too. So what about some of the other benefits? And since this is being recorded, I'm just going to change the names. And this is what makes it important, you know, being a doctor. Our real benefits from doing this research. This was Hannah. She wasn't going to go to college because she had inflammatory bowel disease, and she really didn't think that she could sit through the SAT exam. she couldn't sit there, and she was too embarrassed and to get up and go to the bathroom several times. She went into remission on our study, and she just graduated last May. So that's a success story, which, you know, we don't put all these in the paper. Keith, he wanted to participate in sports, but he was the scrawny kid, and nobody would choose him for the team. He went into remission, and he was on the, he actually became the captain of their high school basketball team. And Karen was a little girl who came to me who had been on immune suppression for her Crohn's disease and had developed a brain tumor and had to have surgery and chemotherapy, and they didn't know what to do because they knew they had to stop the immunosuppressive medications, one, because it may have caused the brain tumor, and two, how was she going to respond to chemotherapy? But what on earth would they do if they stopped all that and her Crohn's flared up? Anyways, she went on the Low Dose Naltrexone, and she's now a sophomore in college and doing very well, and it's the only medicine she takes to control her Crohn's. So those are the benefits and some of the success stories, and there's many more. So what's the advantage of naltrexone? It can be given orally. It may downregulate, but it doesn't completely eliminate the inflammatory cytokines, so that's why we don't have risk for infections. It has very few side effects. There's once-a-day dosing, and it's cost-effective. So why take biologics? You could tell that I'm not paid for by the biologic companies. And we need to learn to think outside the box. And I want to thank you all for being here today, because it's because of people like you who are willing to think outside the box. There's a lot of things that we still don't know. You know, why is low dose better than high dose? Does it have to do with the receptor affinity, that it goes to one receptor over the other at the low dose? What role does naltrexone have in restoring the innate immunity and immune homeostasis, which might be out of whack in people with autoimmune diseases? And what is the mechanism in autoimmune disease and inflammatory diseases, and is it different than what we know about it in cancer? We can't just say that the mechanism that works in cancer is the same for all these other conditions. And will naltrexone work better if we discontinue the other immunosuppressive medications? That's a big question. We allowed our children to continue under other drugs in the study, but maybe they would have done even better if we were able to stop the other drugs. So where do we go from here? After we did our children's study, we secured the FDA orphan drug status. So the FDA has approved low-dose naltrexone for children with Crohn's disease. It has orphan drug designation. We'd like to know if it works in ulcerative colitis. We haven't done any studies in that, or other autoimmune disorders. We did have a patent on this, which is being licensed and developed by TNI Biotech, because in order to get doctors to prescribe a drug in the United States, it has to be FDA approved in order to get the majority of doctors to prescribe it. So we have to abide by the rules and do that. So TNI Biotech gave me a slide to include, just so that you know what they're doing and what's happening with maybe developing this compound. They're planning to do a phase 1 pharmacokinetics trial in healthy volunteers. We hear all this question about, you know, should you use 1 milligram or 6 milligrams? They're going to do PK studies, and they're going to measure it, and they're going to get us some scientific data. They're planning to do an adult phase 2B and phase 3 trials in inflammatory bowel disease, and that's going to be coming up. They're planning to also do trials. They're going to be doing them both in Europe and in the United States. So if any of you are interested, you know, tell your doctors about it. They're going to include adults first, and then they're going to move on to children. And all of these studies will be posted on the clinicaltrials.gov website, because according to the law, you cannot publish your paper unless you've posted it on the website here. So watch on the clinicaltrials.gov website for all the studies that will be coming out. And if you have questions about TNI Biotech, here's their website if you need additional information. And I'm sure that they'd be happy to answer whatever questions that you might have. So in conclusion, naltrexone therapy appears to be effective for active Crohn's disease. It's well tolerated, inexpensive. It's given orally once a day. The mechanism by which naltrexone works in inflammatory bowel disease might be through opioid blockade on the inflammatory cells. It may also cause mucosal healing by acting through the OGF receptor, or it might augment the innate immunity, or it could be all of these things. Because of everything that was out there about the taking low-dose naltrexone at nighttime, and because of some of the preliminary work Dr. Zagon had done looking at endogenous opioids having a diurnal release and them being released the most while you sleep, we thought we would give it at nighttime. So all of our patients, we started off giving it at nighttime at the 4.5 milligram dose. If they were unable to sleep after several days and couldn't tolerate it, we switched it to the morning, and it didn't seem to affect whether they responded to the treatment or not responded to the treatment. But we haven't done an official study to compare morning versus evening dosing.
I've actually got a couple questions. First, I appreciate what you do and for your time. Have you seen anything with people with digestive issues and taking LDN and maybe absorbing LDN?
Sure, I'll answer.
Okay.
Naltrexone is actually absorbed from the second portion of the duodenum. And so if people have duodenal conditions such as Crohn's disease, which can involve the duodenum, celiac disease, they may not absorb naltrexone as well by mouth. And so also in some of my Crohn's patients, when they flare up, they're not going to absorb it as well. So we switch to a transdermal cream in those conditions.
Cool. Second question would kind of be along that same line. What about people with candida or intestinal yeast overgrowth?
Usually the candida overgrowth doesn't involve the upper GI tract as much as it does the colon. So it probably shouldn't affect, the absorption of naltrexone.
Okay.
But the microbiome is a whole nother discussion, and how that regulates our immune system.
Okay.
But
Appreciate it.